Today, we'll talk about left-to-right shunting. This is the fourth part of the lecture. Inshallah, the fourth and the last part. We will talk about just one slide about this defect, the Gerboudi defect or Gerboudi syndrome. It is a shunting between the left ventricle and the right atrium. Normally, there is the tricuspid valve is apically displaced towards the apex than the mitral valve. So the mitral valve and the tricuspid valve are normally not on the same level. The tricuspid is displaced about 1 centimeter or half centimeter, apically displaced. This is normal. Sometimes the space between them, this half centimeter, may be defective, causing a shunt between the left ventricle and the right atrium. I forgot to tell you in the previous lecture that part of the AV canal, or a diagnostic feature of the AV canal, is that we find that the mitral and the tricuspid valve are at the same level. This indicates indicates that this case is a canal, especially if it is a partial AV canal. Maybe I'm looking at in a view that does not that the ASD is not apparent, or maybe the ASD primum is small. So if I find the tricuspid and the mitral are at the same level, this indicates this is a canal. If this displacement is further than 1 centimeter, this is diagnostic for Epstein anomaly of the tricuspid valve. So the tricuspid is apically displaced more than centimeters into the right ventricle. We'll talk about it later in another lecture in the right side obstructive lesions. So in the Gerboudi defect, there is a shunt from the left ventricle to the right atrium. Other complex anomalies may give rise to the same shunting. Like, for example, a mitral regurg in which the jet is anteriorly directed, accompanied with an ASD, so that the anterior directed jet, flows through the ASD into the right atrium during systole. This gives rise to an LV to RA shunt. Also, a perimembranous VSD with tricuspid regurg, in which the blood during systole, the blood flows from the left ventricle to the right ventricle and then through the tricuspid valve to the right atrium. So this is also a form of Gerboudi. I can show you in one of the this is an AV canal. So the mitral and tricuspid are at the same level. So this is a primum AV canal. Mitral and tricuspid are at the same level. There is no apical displacement of the tricuspid valve. Okay, now we'll go back. Talk about DORV, double outlet right ventricle. We usually find DORV and DILV, double outlet right ventricle and double inlet left ventricle. But it is very rare to find the opposite. It is very rare to find a double outlet left ventricle or a double inlet right ventricle. This is because in the embryology, the common atrium or the sinus venosus connects to the rest of the heart tube via an AV canal. Then the blood flows towards this part of the tube and then passes through this narrowing to the other part of the tube, and then the common outlet, which is the truncus, flows to the body, to the whole body and the lungs. So this is the pathway of the blood in the embryo. Later, the AV canal is divided into mitral and tricuspid, and this part of the tube later forms the left ventricle, and this part of the tube later forms the right ventricle. So in the embryology, the precursor of the left ventricle receives the blood from the AV canal, and the precursor of the right ventricle delivers blood to the truncus. So if part of this formation prevails after birth, so we will find that the left ventricle may receive the mitral and tricuspid, and the right ventricle may deliver the aorta and pulmonary, so it becomes double inlet left ventricle or double outlet right ventricle. But the opposite is difficult. For the AV canal to be superimposed upon the right ventricle, or the truncus coming out of the left ventricle, it's much rarer. So this is the reason why we find DORV and DILV much more common than DOLV and DIRV. Later, the heart undergoes remodeling or remolding of its anatomy, so that the right ventricle receives the tricuspid valve. Septation occurs in the interventricular septum, and the aorta migrates towards the left ventricle. This is a case of DORV. So the aorta and pulmonary arise from the right ventricle. The aorta here didn't migrate enough to be above the left ventricle, so it remains above the right ventricle. If you notice, the only outlet of the left ventricle is a VSD, so a VSD must be present. An absence of a VSD is incompatible with life in these cases. There are 4 types of DORV, depending upon the position of the VSD and other factors. So the position of the VSD determines at least 2 types of DORV. If the VSD is subaortic, so the blood from the right ventricle, this is a view from the right ventricle. The blood from the left ventricle at the back flows through the VSD, and it finds the aorta facing it. So during systole, the jet of
اقتربت صلاة العشاء.
out of the jet of the blood coming out of the left ventricle flows by jet propulsion into the aorta, and then some blood escapes through the right ventricle and then to the pulmonary artery. So part of the cardiac output of the left side is shifted to the right side. So this pathology is similar to a VSD. So we call it the subaortic VSD. We call it the VSD type, DORV VSD type. So a subaortic or non-committed VSD, a VSD type, is managed like a VSD. What if the VSD is under the pulmonary, is subpulmonic? So by jet propulsion, the blood from the left ventricle at the back flows into the pulmonary artery, and some blood escapes or escapes to the right ventricle and then to the aorta. And the blood coming from the vena cava will find the aorta, will find the pulmonary more occupied by the jet propulsion of the blood from the left ventricle. So the blood from the blood from the vena cava will find it easier to flow to the aorta. So this is a pathology similar to a TGE. So we call it the DORV TGE type or Tau-Sig-Bing. So a subpulmonary VSD TGE type or Tau-Sig-Bing is managed like a TGE. In a subaortic VSD with a pulmonary stenosis, or even in a subpulmonic VSD with a pulmonary stenosis, so the presence of a pulmonary stenosis, whether it is subaortic or subpulmonic or non-committed, blood will find it difficult to flow through the pulmonary artery. So most of the blood will flow through the aorta, and some blood will pass through the pulmonary stenosis, and right to left shunt will occur, and this is a fallow type, and it is managed like the fallow. If the left ventricle is rudimentary, being just a pathway for blood from the pulmonary veins to the VSD, so the left ventricle may become rudimentary, may get smaller, so the ventricles become unbalanced. So we call it single ventricle type, DORV single ventricle type, and this is managed like a single ventricle. We'll talk about it in a separate lecture, the single ventricle pathology. Okay, surgical closure. What will we do? In the VSD type, we baffle the VSD to the aorta to prevent the escape of blood to the right ventricle and pulmonary. So we cover with a patch the pathway of blood from the VSD to the aorta with a patch, so that the blood in the left ventricle will flow to the aorta only without going to the pulmonary. So this is how we correct the VSD type. The pulmonary type, we want to do the same, but the VSD is away from the aorta, so we can't put a patch that gets the blood to flow from the VSD to the aorta. Maybe it's not accessible this way, or even if we put such a patch, the blood flow will be restrictive. So what we do is that we cover the pathway of the blood from the left ventricle to the pulmonary with a patch to prevent the blood escaping to the right ventricle, and then we switch the arteries. So we do a baffle and an arterial switch in the TGA type. So the DORV TGA type is corrected by an arterial switch operation and the baffle of the VSD to the pulmonary. So the VSD, the baffle VSD to pulmonary artery plus arterial switch for Taussig-Bing type. The fallow type is managed like the VSD type plus the correction of the pulmonary stenosis, either pulmonary valve repair, RVOT patch, transannular patch, pulmonary valve replacement, whatever is necessary. Single ventricle management for the single ventricle type, or if any of these types are unrepairable for one reason or another, so we go to the single ventricle pathology. Intraoperative, the management is according to the type. Usually involves balancing the superior vena cava, the SVC, the systemic vascular resistance and pulmonary vascular resistance. Conduction abnormalities are common after baffling. Now we'll talk about Truncus arteriosus. There are several types of Truncus arteriosus. This is type 1. Pulmonary and aorta are side by side from a common valve, truncal valve. Type 2, the pulmonaries are, and type 3, the pulmonaries are branches from the aorta or from the trunk. And in type 4, the pulmonaries are branches from other, not from the ascending or the truncus, but from the descending, from one of the branches of the arch, from the great vessels. And sometimes this type is considered a pulmonary atresia with enlarged mapcas, so we may consider those to be mapcas. Actually, they mostly they are, but they are managed like a Truncus arteriosus because the pathology is similar. Pulmonaries are branches from the aorta. Truncus may be associated with DORV or velocardiofacial syndrome, thymus aplasia. So these patients may be immunocompromised. So we take great care with infection control and antibiotics. Also, we prepare irradiated blood for these patients to prevent graft versus host reaction of the unit of blood against the patient, because the patient is immunocompromised. So the white blood cells in the blood unit may attack the patient. So we irradiate the blood. Parathyroid aplasia, the patient may be hypocalcemic. In the velocardiofacial syndromes, palatal and craniofacial abnormalities may be present, so difficult intubation may be found. Neuropsychiatric disorders, delayed learning and speech. Preoperative assessment, general considerations for left to right shunting. Baseline saturation is very important. Cyanosis may be caused by either bad chest condition or congestion, or by pulmonary hypertension. Congestive heart failure occurs very quickly because the lungs are perfused directly from the aorta and very close to the heart, so the lungs receive a huge amount of blood. So a congestive heart failure may occur with low systemic cardiac output and high pulmonary cardiac output. Fall in neonatal pulmonary vascular resistance worsen the symptoms. This is very important. Low diastolic pressure due to runoff of the pulmonary circulation causes low coronary perfusion and myocardial ischemia. So if the pulmonary vascular resistance falls for any reason, including induction of general anesthesia, so blood will flow more to the lung during diastole. It is something similar to severe aortic regurg. So during diastole, the blood, the diastolic pressure does not stop at the diastolic pressure. It falls and falls to the end of the diastolic time. So the blood may fall to dangerous levels that may compromise the coronary circulation, because the coronary circulation depends on the blood in the coronary flow during diastole, not during systole. Because during systole, the myocardial contractility prevents coronary flow or decreases coronary flow greatly. So the perfusion of the myocardium depends on the diastolic time and the diastolic pressure. So blood running off to the pulmonary circulation would compromise the myocardium, causing ischemia. So this is very important during induction of anesthesia. Furthermore, what may increase the severity of this condition is the truncal valve insufficiency. If there is an insufficiency or regurg in the truncal valve, so more runoff will occur to the left ventricle during diastole. So the diastolic pressure may severely decrease, causing further ischemia added to the pulmonary runoff. Signs of pulmonary hypertension, it develops very early, and most patients die within the first year. Why it develops early? Because of the pulmonary arteries are large, non-restrictive, and are branches from the ascending aorta or from the truncus. So the closer the branches, the pulmonary branches, the pulmonary arteries to the left ventricle or to the heart, the more the blood flow, the more the congestion, and the rapidly will develop the pulmonary hypertension. Also, coronary abnormalities may be present. So all these are challenges for the Truncus arteriosus, and you should be warned that Truncus arteriosus is a very critical case, and the mortality rate is high. It's a very dangerous case, whether to anesthetize for cardiac or non-cardiac surgery. So we should give great care for these patients and great caution. Surgically, They are usually neonates. Contraindicated is pulmonary vascular resistance is high, more than 8 Woods unit, or Eisenmenger syndrome. Detached pulmonary artery, right ventricle to pulmonary artery conduit, or direct anastomosis of the pulmonary artery to the right ventricle. This may be done, but it has the problem of putting tension on the sutures, because we pull the RV towards the pulmonary and the pulmonary towards the RV, so this may cause the heart to be rotated, the apex to be rotated anteriorly, and this may compromise the venous system of the heart and may compromise the hemodynamics a little. But the advantages of this anastomosis is that we do not put a conduit, a small conduit, in such a small patient, because the patient will rapidly outgrow the conduit. So we do not put any foreign body inside the patient and allow the patient to grow. So on the long run, this surgery is better than this conduit. But immediately post-operative, this direct anastomosis poses greater challenges. Truncal valve repair, if there is a regurg. We may leave an ASD to vent the high right ventricular pressure at the expense of some desaturation, because many of these patients are pulmonary hypertensive. So post-bypass, we may find a high pulmonary artery pressure that may render weaning from the bypass difficult. So an ASD will relieve the RV pressure and allow for weaning from the bypass and better hemodynamics at the expense of some cyanosis. The surgery is that we open the RVOT. We put a patch to allow the blood from the left ventricle to pass to the truncal valve and prevent blood from the right ventricle to go to the truncal valve, and then we close the right ventricle and put a conduit from the right ventricle to the pulmonary artery. The other technique that I talked to you about, and we separate the pulmonary artery from the truncus. Otherwise, the other surgery is that we take part of the truncal valve. We do not separate the pulmonary artery this distally. We separate it more proximally, and we may take part of the truncal artery, and then we pull the pulmonaries towards the right ventricle and the right ventricle towards the pulmonary, and we directly anastomose them together. Plus we do a Lecomte procedure in which the aorta is dissected and the pulmonary arteries are taken anterior to the arch to allow more anterior positioning of so that we can pull the pulmonaries more towards the RV. Intraoperatively, be very careful with inhalation induction if needed, and better avoid inhalation, not to lower pulmonary vascular resistance. Lowering pulmonary vascular resistance may precipitate myocardial ischemia, as we said before, due to the runoff of the blood towards the pulmonary circulation and sometimes towards the LV in the presence of truncal valve regurg. Efforts should be made to keep the QP/QS around 1:1, keep diastolic pressure high by keeping high pulmonary vascular resistance and by keeping some tachycardia. The tachycardia decreases the diastolic time, so it does not allow the diastolic pressure to fall to dangerous levels. The surgeon may snare the pulmonary artery and bend it a little to decrease the runoff, and actually this maneuver helps greatly in critical cases. Sometimes after induction, the patient, despite all of these efforts, the patient becomes ischemic, and we can see low blood pressure, the ST elevation in the ECG, and the condition becomes highly critical, and we sometimes see ventricular arrhythmias, sometimes patient arrests. So we urge the surgeon to open the patient quickly and then to bend the pulmonary artery. This bending improves the condition dramatically. Just by bending the pulmonary artery, the condition improves, the blood pressure rises, the ECG changes improve or resolve completely. So it's important to put this in mind. Extra care is given in cases of truncal regurg. Ischemia may appear as arrhythmia up to VF. Going on bypass without delay is generally the aim. So during induction, I should make sure that the surgeon and the scrub nurse are ready for rapidly opening the patient. So I should not start induction of this patient unless I'm sure that the surgeon is in the OR. Irradiated blood and calcium replacement if the DORV syndrome. After sternotomy, if the surgeon finds the thymus gland, then these precautions are omitted. Because if he finds the thymus gland, then this is not a DORV syndrome. Actually, in these cases, if the patient is pulmonary hypertensive, all these problems may not be faced. If the patient is pulmonary, so if in the preoperative assessment, if I find the pulmonary pressure high, or the saturation is low around 80 or something like this, so I will expect that the induction will be safe, or induction will be non-eventful, but the post-operative course may be difficult. This patient post-operative may have residual pulmonary hypertension, may have a pulmonary hypertensive crisis, may have an RV failure, so an ASD should be left to allow for some venting. So ironically, a pulmonary hypertensive patient can more easily be anesthetized, but the post-operative course is more difficult. However, a patient without pulmonary hypertension, the induction may be hectic, may be very dangerous, but the post-operative course is much better because of the lack of pulmonary hypertension. Many issues can render weaning from bypass difficult, like residual pulmonary hypertension, residual myocardial ischemia or stunning, because the bypass, the cross clamp time is prolonged. So the myocardium may become stunned. Arrhythmias, conduction abnormalities, truncal regurg stenosis. You have to expect that a truncal valve regurg is difficult to repair and difficult to replace. So the truncal valve regurg is a real challenge. A regurg in the truncal valve in such a neonate is a real challenge. So such a repair may not be easy. Residual VSDs. Epicardial echo is useful in these cases because usually the infant is too small for TE, or the neonate is too small for TE. So we have to put in mind that as a summary, or in short, in these cases, these are highly critical cases. A good patient preoperative may have a stormy induction, but good weaning from bypass, and a bad patient, a pulmonary hypertension patient, may have a smooth induction of anesthesia, but a stormy weaning from bypass. AP window. This is a condition very much similar to the Truncus arteriosus in its severe forms, and very similar to the PDE in its milder forms. So it is a window between the aorta and the pulmonary due to an incomplete separation of the truncal of the Truncus arteriosus. So it leaves a hole between them. If this hole is small, so this case will be similar to PDE. if the hole is large, so that almost the aorta and the pulmonary are non-restrictively connected, so it becomes Truncus arteriosus, or very similar to Truncus arteriosus, but with two separate valves, the aorta and pulmonary. But the pathology is very similar to Truncus arteriosus, and the management is very similar to the Truncus arteriosus, with the same risks and the same high critical conditions, the same risk at induction, the same runoff of blood to the pulmonaries, the same condition. The more proximal the connection between the systemic and pulmonary circulation, the worse are the symptoms. So an AP window is more severe than a PDA because the connection is closer to the heart than the PDA, usually associated with other abnormalities. Preoperative assessment similar to the truncus. Severity depends on the gradient across the defect and or the ratio between the systemic and pulmonary vascular resistance, depending on whether the defect is restrictive or not. Signs of pulmonary hypertension development very early, can develop as early as 12 days. Most die within 1 year, like the Truncus arteriosus. Surgically, usually neonates, varies from simple ligation without cardiopulmonary bypass. If it is just a small hole, we may just ligate it like a PDA. If it is larger, we may close it on bypass by a patch. If it is very large and close to the arch, so we will not find a place to put the cross clamp, so a deep hypothermic circulatory arrest may be needed. In large defects that are more distal in the ascending aorta, may be closed by a percutaneous device in cath lab. If the device is, if the defect is small, we may close it by the device. So the presentation is highly variable in these cases, and the management is variable accordingly. Intraoperative, similar to the Truncus arteriosus. Postoperative, many issues may render weaning from bypass difficult. Similar also to the Truncus, residual pulmonary tension, residual myocardial ischemia or stunning, arrhythmias, conduction abnormalities. And thank you.